Thank you so much, Carol, for the lovely introduction, and welcome everyone to this very important discussion on building healthy community outcomes. We have three distinguished guest speakers with us today: Dr. Kimlin Tam Ashing, professor at City of Hope Comprehensive Cancer Center; Dr. Mo Ma, a breast surgeon with Scripps in San Diego and previously with Mount Sinai in New York City. I'm currently the co-director of Scripps and MD Anderson. And we also have Jenny Lowe. Jenny is a cancer survivor and a passionate community leader in Lower Manhattan. Welcome, everyone. To get our discussion started today, I'd like to put forward a few items to think about. Although there are declining overall mortality rates in cancer patients in the US, there's a persistent disparity in incidence and cancer-related mortality rates among different races and ethnicities. Asian community is very diverse. There's Korean, Chinese, Japanese, Filipino, people from Laos, Vietnam, Indonesia, as well as Pacific Islander groups. But they're usually lumped together in analysis and averaged so that the numbers don't always show or help attend to the more vulnerable in the Asian groups. Racial and ethnic minorities have been shown to have worse outcomes and receive a lower quality of healthcare than those of non-minorities. This has been attributed to decreased access to necessary healthcare due to socioeconomic status, language, geography, and also cultural familiarity. There's a great need to educate both healthcare professionals as well as patients regarding the racial disparities in order to better provide quality healthcare for patients. Most previous retrospective studies or even prospective studies that I've seen have investigated racial disparities between Black and whites, occasionally examining disparities for Hispanic patients. Studies including Asian or Pacific Islanders are extremely rare. And I have not seen any studies that compare the varied Asian groups across the board. So today, with our three distinguished speakers, we would like to examine some community-specific areas. I would like to open it up to our panel. Are there cultural issues with caring for patients directly or through interpreters that you deal with on a day-to-day basis? Dr. Ma, would you like to start?
Yes, in day-to-day basis, whenever I'm seeing a patient with different language, there's significant language barrier, especially when they don't speak English. Even, they have options, and depending on which institution you are in, sometimes they will let you use family members as translator, and other times you have to use institutional translator, and that can be somebody over the phone, sometimes on a video, or sometimes in person. But when it comes to these few minority groups like Vietnamese, Cambodians, or Indian language, or even sometimes other smaller minorities, you can't get translators. Yeah. So many issues with language. Even when you do get a translator, they're not fluent in medical terms, and I can tell many times that they're not relaying the same information that I'm trying to tell the patient. So not only that's one thing, information is not being relayed correctly, and then for healthcare provider like me, whenever I have to see these patients, the time frame that I need to see them is longer because it's double, because everybody's saying things twice, right?
Yeah, that's true. Thank you so much, Dr. Ma. How about Dr. Ashing? Have you seen similar in your area?
Yes, well, in California, we have a high density of Asian populations, diverse Asian populations. So US Asians come from over 30 different countries and speak over 100 different languages. I think that where institutions are trying to address cultural competency, it is a challenge with the Asian community, 100 different languages. I think for institutions where cultural humility can go a long way. So you may not be able to speak the language, and certainly there are accessible translators that are not, it's not the perfect remedy, because sometimes it's on the phone, sometimes it's video. But understanding the culture and understanding sort of the humanity of the patient in front of you, addressing that person with respect and humility goes a long way in terms of cross-cultural healthcare and medical care, especially in the cancer realm that is so complex, and you're seeing so many different clinicians, radiologists, a surgeon, oncologist, to say, the least, that approaching that patient with cultural respect and dignity and cultural humility goes a long way in terms of making a bond and developing, that clinical trust that is so needed for us.
Completely agree. And Jenny, as a patient, what have you experienced?
So I so agree with Dr. Ashing's what she said, and Dr. Ma. So I am trilingual, and I speak English. Even as a patient, I feel the difference with the, various medical professionals that I have encountered. Right, there's a difference between talking to me as a patient, as a person, not as a patient, meaning that I have encountered medical professionals treat me like just a patient. What that means is that I'm here to solve your problem and that's it, and nothing else. Even in the tone, in the way they speak to you, their mannerism is so different. I am just so fortunate to have had an oncologist who treats me, I can still see her, as a person before she treats me as a patient.
And probably has better discussions with you around what's important to you as a person.
Yes, absolutely. She wasn't here to just get rid of my cancer or just remove the cancer, but she was here to talk to me, and that's how she started with. And I feel the difference because I've had subsequent other serious issues where I have seen other doctors, and there's even a difference between. I hate to say it, but there's even a difference between male and female doctor. And I think as a patient, as a female, I would say that without offending all the male professionals, that there is a difference, and that really I don't know how to describe it, but there is a difference.
Sure. Now, what are some of the priorities, some of the things that you think are really important in this patient population, people with cancer, and how do we start talking about those disparities in a way that we can move forward aspects of it, either in policy, either with physician discussions, awareness, however you think about it. I would love to hear from the panel. What are some of your priority thoughts?
For me, what's important is that, previously working with a group like SHARE, having a patient navigator really makes a big difference, especially in minorities population, mainly because by having especially a cancer survivor as a navigator makes a big difference. Just by having their presence in the office, they can see with their eyes that, yes, they can survive this disease, there's hope. And many times the navigators also can, minorities as well. So, even when there's a barrier with the healthcare providers, it's a big difference.
Dr. Ashing or Jenny?
Well, I would say that a navigator is absolutely helpful, but if you're laid up in the hospital bed, you need an advocate. Just like when you are drugged up and whatever it is in the condition that you are in, you cannot advocate for yourself no matter how fluent you are in the language that you're speaking with a healthcare professional. And I have that direct experience where a healthcare professional, no matter how caring they are, they still don't know who you are. So having an advocate whose goal is just to look out for you and with the institution, right? Because not criticizing the institution, they have so much on their hand, and you having an advocate just whose job is to look out for you is very critical.
I agree, and I think there's so many actually priorities when it comes to ethnic minority and minority and low SES patients. What we see is that, especially among Asians, that there is very little data available on the Asian community and cancer. We don't understand or know what are the distinct differences in terms of screening practices, cultural beliefs, survivorship outcomes. So we need to have institutions and healthcare settings pay attention to the needs of the patients. So what are the requirements depending on that family need? So who are the patients? Jenny talked about the advocate. So you need both a healthcare advocate as well as a family advocate. And that family advocate may vary depending on that particular family. It may be influenced by culture, by religion. And so to ask that patient and not assume that it's going to be the husband or the spouse or the partner. It could be a sister. It could be the oldest child. And so I think connecting with that patient, so to understand what are the specific needs of that patient. I started also talking about the data, that much of policy as well as care practice are driven by data. And if we don't have the data available on our diverse Asian communities, it means that our policy and practices are not going to be responsive to the community.
That's very true. But how important do you think is for the practitioner to actually culturally understand the patients that are in front of them? They may not be aware of all of the various Asian peoples out there. So how do we make sure that they ask the right questions to get to what is culturally important to that patient that's sitting in front of them?
And that's such an important question, Gisu, because we're not going to know all of the different culture. That's not possible. So the approach is cultural humility. So being able to recognize that even as a provider or a researcher, that you don't know all of the aspects of that person's culture. But in an approach that says, I understand that you may have values or practices that are important to you in your cancer journey. How can we understand and help and acknowledge that? How can we make you feel more comfortable, more safe, more trusting of our care that we're giving you? Because this is going to last, cancer care lasts for quite some time. And we know that survivorship care and follow-up care and surveillance goes on, right? And so we need to develop a long-lasting, trusting relationship with our patients. And so that cultural humility and that relationship and that bond, and as Jenny spoke about before, of treating the patient as a person, so not just a patient, not just as someone who has cancer, but as a person, and really a whole person, a whole care approach would be most helpful for any patient.
Do you think it's important for patients to see physicians that look like them? Yeah, Jenny, go ahead.
Yes, absolutely. When you look at someone who looks like you or closely looking like you feel immediately comfortable. I mean, there is just a sense of unspoken unspoken understanding that you feel when you look at someone. So even just without being about ethnic group, but just if I see a female doctor, I kind of feel like she understands me already. There are things that we female understand that we don't have to speak, right? So I think that's just instinct. There's nothing biased about against someone other different than us. It's just we're human beings. We feel more comfortable when we see someone who is similar to us in any way.
That's very true. Dr. Ashing or Dr. Ma, have you found this with patients that look or are similar backgrounds than yourselves? Do you put them at ease immediately by being you?
I haven't noticed. I also try not to put a lot of not a lot of factor in that. I like to believe that all doctors should provide all patients with equal quality of care. So, yeah. But as Dr. Kimlin was talking, Dr. Ashton was talking about on cultural issues, and humility is, I guess, one of the ways that we can approach the patient is with a lot of open-ended questions, and also validating that their cultural background is important in our conversations. That can help.
Have you built communities or worked with organizations that have built communities for underserved patients? And what's worked, what hasn't worked? What do you want to push forward more of?
Yes, I think that is so critically important, because building partnerships, alliances, trusting productive relationships with community advocates, that's key to learning about the various communities, about having the communities feel safe and comfortable with working with you. So for example, I work with multiple ethnic groups and multiple Asian groups, because I live in California. This is my community. I want to serve all those, especially those who are underserved. And so our community advocates are trusted health leaders within their communities, and they can be, holding your hand and guiding you through understanding the community, and being able to do your research as a researcher, whatever little data there are available on, say, Filipino Americans, on Chinese Americans. Understanding the context of immigration, why people left their homeland, those contexts are also important. And understanding their cultural beliefs about cancer. Some cultures, it's still very much a stigma. In some cultures, there may be beliefs that cancer can be contagious. And so understanding some of those, but also being open, that cultural humility again, that it may be part of some of the cultural beliefs, but each patient, each family may express that differently. And so being open to understanding some of the cultural beliefs and practices, but again, that humility of individually working with the patient, the family, the community that's in front of you.
So for me, that's about developing trust, right? It's very difficult for a healthcare provider to develop a trust with the 5 minutes, 10 minutes, 20, 30, 45 minutes office visits. However, if the patient is coming from a community who already have experience with the provider, then it's very easy for me to develop that trust with the patient and provide the care that is needed. Otherwise, there's a lot of mistrust, and that's just makes a worse outcome than others in general.
Absolutely. Do you find the same types of questions being asked to build that trust, from a patient? Do they ask you the same type of questions about the system maybe, or about what the next steps for them would look like, things like that?
it also depends on their background as well. You know, some cultures tend to ask a lot more questions, other cultures don't. Yeah.
That's true.
Or they don't talk about it at all because
Right.
it's so taboo to talk about it, so they don't talk. I mean, Dr. Ashing says some cultures think this is contagious. It's not even just about besides that is you don't talk about it. That's if you use the word cancer, it's gonna make you die. I mean, I experienced that with my own family, and so frankly, I really never talked to my mother about my breast cancer until after I finished the surgery, because she would be so scared. She thinks saying the word cancer, I'm gonna die instantly.
Yeah, it has changed over time, but still, folks that are fresh, to the U.S., they still have that cultural understanding that they brought with them. Have you found that people that have lived in the U.S. for a long time, have they assimilated, or are there still some things that they hold on to from their old culture?
I'm so glad you raised that, because I think as an immigrant myself, I think sometimes we ascribe to what's called cultural preservation. So even though we've lived in the US for 30, 40 years, sometimes we adhere to the old culture even more than some of the folks who are in that culture of origin, because we are in a different country. And so we want to hold on to our beliefs and practices. And I think the medical community need to understand that and not say, well, you've been in America and you should be American, because acculturation and our preservation of our cultural values sometimes can be even stronger because we have left our home country. And, that affects things like social support and family communication, as Jenny was just speaking to. And so it's so important to, as researchers, as clinicians, to encourage the family to talk about it, because it also would impact quality of care and maybe even things like genetic counseling or genetic testing. Because if it's a cancer that requires earlier screening or genetic counseling or testing for the family member, for example, ovarian cancer, right? That automatically triggers genetic testing for all of the first degree relatives. Well, that would be important to communicate in order to have good preventive care. But again, you're challenging that culture who says we can't speak about it. And so that family advocate that Jenny talked about, so you need an advocate within the healthcare system, but you need an advocate within that family, someone who sort of is the bold one in the family and the one who is the historian, the one who challenges the family norm. Get that person on your side to be able to say, we need to have a family discussion about this and engender that family support that we all need. And we see differences in some of my earlier research that actually the Korean American group indicated the most challenging time in family communication, even more so than the Chinese or the Japanese American. So there are cultural differences, and understanding that and encouraging the family, who in the family can help you kind of bridge this gap to talk about it, can be so helpful to the patient.
It is. How do we overcome the stigma, though, that comes with cancer? I mean, Dr. Ma, you work with patients directly. How do you see that manifest itself? How do we overcome the discussions with the bold one in the family, for sure, but it's broader. You need to talk to the first relatives of. So that makes it a little bit interesting, to say the least.
It certainly is better if there is trust. So community help will help too. Education.
You find that a lot of people don't want to know about it, or they're information seeking? I guess that's the question.
Many times they don't want to know about it and they don't want to talk about it.
That makes your job a little more difficult. Jenny, you had something that you wanted to say? I saw you.
It's all that what Dr. Ma said is also this a sense being like shameful to be ill with cancer. So you don't want to tell people about it and you don't want to say anything about it. And I don't know why, right? And I guess Dr. Ashing, you're right. It's because some of the cultural people hold so dearly that it may have permeated to, now that we're in America, it's different. In order for us to be able to get the best care, we have to share with the healthcare professional of everything that we need to, that's relevant to the treatment, right? And maybe that's the case.
So how do we build awareness and change behaviors for everybody, not just the patients, but also the providers, to have that open and honest discussion? Even though it's hard and there's stigmas attached to it, if you have colon cancer, right? Nobody wants to talk about it. But how do we build those close relationships? Is there something that the community as a whole can do so we can all push at the same rate forward for those patients?
So what you're essentially saying is trying to change the culture.
Well, if they come to the US and they have cancer, there's stuff we could do for them.
Well, I think
it's difficult. It's not easy.
Well, I think Cher's mission is on the right track. I believe that having when I first met with Cher a few years ago, having I guess ambassadors. I forgot the name.
Yes, ambassadors.
So I think great, and I think if we can. The Asian community will work with Share and have incorporate that cultural aspect of it and have ambassadors who could. I think it's a slow process, Dr. Ma, right? You're talking about changing culture. Maybe it's more about changing mindset, right? That takes a long time. And I think it will happen if we have people who are committed and passionate about helping those of us who are in America and encounter health issues, especially like cancer. And how do we help them have better outcome, right? Because how the patient feel about it and how their families feel about it, I believe have a lot to contribute to the outcome of the treatment.
Another way is to force people to change the situation, right? You make rules and regulation that this is what you have to do.
Yeah, but what are some of the key strategic changes that we can make, either rules from a policy perspective or just to anything that we can do? Maybe it's a study to actually quantify the number of patients that are out there, but to make it better, improve cancer care outcomes for those patients.
I think communities, healthcare institutions, and insurance companies needs to have some ownership in this. For example, patients tested with genetic testing positivity, they have to have staff members have allowance to say that, is it okay if I share some of your results with other family members?
Or even to put it into a study so it could be captured as evidence. Right? Building that evidence that we need.
So we need engagement from all parties. And I love that comment that Dr. Ma made in terms of, payer structures too, that, the cost of diagnostic tests and genetic counseling needs to go down to make it more affordable. So that's one of the barriers. And I think as we engage in this community of accountability to better healthcare, it would be great to look at, the cultural tailoring of, educational materials. So one time I saw this one, you make time for dim sum, make time for a mammogram, so that we are really working with the culture to say, here is a message that's targeting you. Because sometimes I've heard from patients, that, Asian women tend to get breast cancer at a younger age. And they go in with, maybe a tiny lump at 35, and the physician is saying, well, you're Asian and you're young. So, don't worry about it. Well, then you want to ask about family history. Maybe you have a conversation that's deeper rather than just turning away the person and saying, well, you're Asian. Well, that's actually not true, because Asian women tend to have breast cancer at a slightly younger age. So then we need to be able to educate the providers, the clinicians, educate the advocacy groups so they can go out and educate the community to stimulate action towards advocating for healthcare. And that's tough because, in many cultures, including many Asian cultures, there's such respect for the physician. So maybe there's some trust issues, but certainly there's respect. So, we may not, challenge that physician. We may not. And so really working with the advocate organizations and working with the providers so that they encourage, open communication, even if that's tough for the community, and really saying to the advocates and giving them the tools that they need to help the community, take action and be activated so that they can say, well, my mother had, breast cancer, or my aunt, it may be something you need to look at and not just ignore the fact that I'm 35 and an Asian, and it's never going to be anything. Just, follow the protocol in terms of, a deeper test, because I have this lump. So really working with the community so that they can be advocates, which can be tough culturally, but necessary in terms of, getting the best care.
Dr. Ashing, what I also heard was that normalizing it, right? Like the dim sum, it made it relevant, yes. It made it ownable. So it's really important to do that as well, to be understanding of the culture and be inclusive, I guess, is what I heard there.
And supporting educational materials through ethnic media, through radio and newspaper and television, that they're, specific culturally targeted shows. And so it would be important to have educational material and ads during those programs.
And also in the mother tongue, I think is very important, right? They would understand it firsthand. Have any of you seen an organization or like SHARE, I know SHARE, put aside, are other organizations or institutions that are really doing it well towards the patient community and educating and making sure that they reduce the stigma associated with cancer?
Well, at City of Hope, we are working diligently to increase our provider population in establishing community clinics. So it's not just the main campus, but community clinics in minority dense and Asian dense communities. We certainly need more providers, as Dr. Ma was speaking to it, in terms of being able to provide, linguistically and culturally competent care. But, for example, in terms of genetic counseling and testing, very few ethnic minorities in general go into that field. This is a field that's dictating how we treat cancer. If we don't have the providers who can, give such deep and important information so that the patient understands that it affects not just the patient, but the family, because this has to do with, genetic testing, we're gonna be left behind in terms of being accessible to, targeted therapies and precision medicine. And so important that we engage in clinical trials. Well, again, if the materials and the person who's telling you about the study is someone who is culturally competent, who expresses this cultural humility, persons are much more likely to say yes and participate and advance, the science and understanding so that we have better guidelines for practice in terms of our care. Because, a lot of these medications that are developed, it's through clinical trials. well, Asians tend to be smaller, right? And less body mass. Well, if the dosing is based on the standard European American, you might have and experience greater side effects. And so we need to advocate our community. We need to have diverse medical professionals from diverse Asian communities and diverse minority communities so that we can better care for our increasingly diverse society.
Very true. Dr. Mao or Jenny, would you like to add anything to Dr. Ashing's comments, which are really on point? My goodness. Yeah, we all agree. Okay. So we only have 15 minutes left and a lot of questions that came in from the audience. So if you don't mind, I'm going to start asking it, and please let me know who would like to answer it. So some of the questions that have come in are, what are the specific caregiver programs and strategies that patient advocacy organizations can implement for the AAPI community?
For me, one of the things that they can provide is having a reliable source of translators. Sometimes institutions are not very reliable, and whoever that translator comes on may not be as fluent as we want them to be. So that's one of the things that community can provide.
Translation and also translated materials is what I hear, right?
Yes.
What we're also trying to do at City of Hope is build a network of patient and family services where it's the services and the care, the supportive care targets the whole family, so that it's not just the patient, but we know that, you know, people live in families and in context. And so that's why we, you know, call it and embrace that patient and family services. So that way, if we develop support groups and working with other communities that offer support groups, it would be important to include the caregiver as well.
Do you think the needs of the caregiver are very different than the patient? Because they sometimes may be a child of someone, and maybe the information that they're gathering doesn't make sense to them, right? And they have to translate it into their parents or grandparents or whoever. What do you think? Are their needs for materials different?
Well, that's an interesting, situation. And in some immigrant families, it's true. Part of the caregiving can be, minors and not just those who are adults. And that's what the family situation, right? That's what the family has to deal with. And how do you help that child? And I think we do not serve children who are caregivers. And it's something that we do need to acknowledge. But in the sense of developing materials to help those family caregivers of all ages, I think would be an important step.
Jenny, did you have, when you were going through your cancer journey, did you have someone who actually cared for you, and were their needs met, do you think?
Well, I did. I have my godmother was very much, who was also a cancer survivor, was there to advocate for me, and it made a difference, right? And I think when you earlier asked about what can the advocacy organizations, what should they do? I think it's about changing the mindset of people and helping the Asian families and the patient themselves understand that this notion of sharing and talking about your experience is important to you, and not just about just helping others, right? Because we, as I mentioned earlier, we think that talking about it talking about cancer makes it contagious, but also this shame of talking about having cancer. So it's all. I guess explaining to understand that it's okay to talk about it, and that advocacy organization is there to help you, not harm you, right? And not that they feel that way, but they're just not used to sharing. And that's a major hurdle, is just acknowledging that help is help, and that it's okay to talk about it.
And also ask for help. I think a lot of people don't want to ask for help, but it's available. It's a good thing to have the help, and also people who understand, who've been through it, because a lot of the ambassadors have been patients and they can actually answer some of the questions that you may not want to ask anyone, but they would understand the types of questions that you need to answer. Anything else before I move on to the next question?
Well, I just wanted to add, in terms of, caregivers, and caregivers tend to be the one who also seek information. And we ought to think about using, Asian specific channels, because there could be a lot of misinformation out there that perpetuates some of the stigma related to cancer and other illnesses. And so I think SHARE and other advocacy organizations can use those platforms to populate and saturate it with positive messages, as well as accurate information about cancer and its impact on persons, especially the Asian community.
I also think patient stories, when people see patients like them in videos or whatever, it actually normalizes it. Here's a person that looks like me that had this disease and they survived, right?
Yes.
I think it will kind of bring down the stigma a little bit. Our next question is the way the healthcare system, is there a way that the healthcare system can help bridge the communication gap with the families? Is there a venue that the healthcare system can do? Maybe this is at the policy level, or helping, Health and Human Services have something direct to patients.
I think they can partner with organizations like SHARE or advocacy organizations. I that's important, because if I'm seeing the institution that I know, the name that I recognize, is working with an organization like SHARE, that really helps make a difference and erase some of my apprehension and fear about the cancer.
And also getting the information from a trusted source is always very important.
Yes. Yeah. And going into the community. So you're not just waiting in your institution, but you're going to the churches or the temples or the mosque. You're putting ads in the local ethnic newspaper. You're creating materials and resources in language with images that reflect the various cultures that you're serving. I think can be so important for healthcare systems to use.
Dr. Ashing, you had mentioned about research in these communities. Do you find that there are enough studies that are actually focused in the community to actually bring these voices into the trials?
Not enough. And I think we have these assumptions that Asians will not participate in clinical trials. But oftentimes we find that actually the healthcare system creates some of the barriers, because we may not ask, because we assume that people will say no. And so we need to understand that patients need to be asked, and they need to make the choice of participating, that the materials need to be translated in language so they could understand. It has to be an informed consent, meaning that they have to understand the parameters of the study. I think also, and this is across many ethnic groups, is that if you have an illness and you participate in a clinical trial, you can get a placebo and or no treatment. And that is absolutely not the case. If you have a medical condition, including cancer, and there are treatments available for your illness, you will get that standard of care. You will absolutely get that treatment. and they will compare it to the experimental group, or the new therapy will be tested compared to the old therapy. No one with a diagnosed illness with treatments available will be left out. That is unethical, it's illegal, it will not happen. So we need
it's
to
one
understand.
Of the myths. It's
Yes,
one of the myths that we need to kind of bring down.
You will get treated. You will get treated if you participate in a clinical trial.
For me, patients should not be denied entry to clinical trials just because they don't speak English. Many patients will not offer trials just because they don't speak English. And the institutions cannot afford translators or services. That should not be the case.
I agree with you. And more studies should be in the local communities where those patients are. So maybe get a translator who can walk through the language of the ICF. I have another question that has just come in. Does HIPAA influence patients' abilities to have their information shared with someone like a family member who's trying to help them advocate?
HIPAA in many ways actually obstructs patient care, especially in minorities, and we need to realize that. And we should modify HIPAA regulation.
Especially if somebody needs the translation and they can't speak English, I think it's really helpful to actually have someone there that could be the between person to help them. I think we are almost at time. We have like 4 minutes. I wanted to give you the opportunity, if there was one thing that you wanted to put forward as something that maybe SHARE can work on to make the patient population get what they need out of the current system, what would that be? From a provider perspective, Dr. Ma, and from a researcher perspective, Dr. Ashing, and from a patient's perspective. We'd love to hear all of that.
For me, navigation works, and I just wish that we will have a lot more navigators from different backgrounds.
Thank you. Dr. Ashing?
I think for me as a researcher, definitely data. We need to have more data on the diverse Asian population, from screening practices to treatment response, clinical trials, palliative care, the whole spectrum of cancer care. We're lacking data on many diverse groups, including Asians. I think it would be important for SHARE to maybe think about a Pan-Asian council, because some of the Asian groups are small populations. So pulling us together and unifying builds a stronger voice for policy, as well as funding priorities and mechanisms that would examine small population, that will target Asian Americans, that will target certain cancers that are more prevalent, like certain GI cancers, gastric and liver cancer, more common in Asian groups. To look at those disparities would be important as well.
Thank you. And Jenny?
And I would say really it's at the grassroots level, where what Dr. Ashing is saying, what Dr. Ma is saying, it really have to mesh and be, when people see those who are like them at the grassroots level, it makes a huge difference in easing their fear and also providing them with, I feel like, more willingness to participate and also to listen. It's a people to people kind of, and it's slow and it takes time and commitment.
Yeah. Thank you so much, all of you, for being here today. This has been a lovely panel, a lot of work to do still, but I think with all of us working together, we can get there. Just before we close, I just wanted to let everyone know that we'll have a short break followed by the Fair Share table discussions. So please make sure that you attend those as well. Thank you all. Thank you for being here for the call.
Thank you.
Thank you, Sue. Thank you.